Good afternoon, everybody. Welcome and thank you for joining us this afternoon. I'm Lucy Hubber. I am the Director of Public Health for Nottingham, and I chair the advisory group for the Local Health and Global Profits Research Project. So incredibly pleased to welcome you this afternoon. We've got a fantastic lineup of Professor Anna Gilmore and Peter Roderick, the DPH for York, who will be taking us through. The webinar will be recorded and is going to be available to view after the event, so other colleagues will be able to see it if you wish to share. Can I encourage you to put any questions in the Q&A function so that we can pick those up, because I am hoping, if I chair this well, I'm hoping that we'll have a good session for questions and answers at the end. If there are any technical issues, then there is an email address that's going to be popped into the chat for you to be able to flag those if you need to. And then just a little bit before we get into the real meat, a little bit of just an introduction of what the research project is. And it's a consortium that is looking at improving our understanding, both the concepts and the local application of commercial determinants of health, and how they affect the health and well-being of our populations. And one of the things that I think is so exciting about it is it's looking at mapping whole local systems to look at ways in which we can reduce the negative impacts on those commercial factors at a real local level. So hopefully some really practical work coming out of it. So if I can, first of all, welcome Professor Anna Gilmore, who chairs the research project and leads a whole range of research at the University of Bath. And I'm sure many of you will have seen the recent series that was in the Lancet on commercial determinants of health. And she's somehow going to, in the next 20 minutes, summarise that fantastic work for us. So Anna, can I hand across to you?
You can indeed. So can you see my screen?
We can.
Okay, perfect. So I always start with my conflict of interest slide because that's best practice, especially in this area, just to flag I don't have any conflicts of interest. And I do it first because otherwise it always really interrupts any presentation. But as we've heard, I'm going to try and talk to you about the Lancet series. I actually led paper 1 in this series. There are 3 papers. And I did participate as an author in both of the other papers. But what I thought today is that we would focus on paper 1, which really had 2 main purposes, and that was defining and conceptualizing the commercial determinants of health, which may sound straightforward. But until that point, really, there was a dominant conception that the commercial determinants of health was just about a few unhealthy products, what we call unhealthy commodities, and the industries that sell them. And 4 of those key unhealthy commodities are detailed in those slides. And the reason that they have garnered such attention is absolutely correct. It's because the scale of the harm from those products is so vast. So the data we pulled together for that paper shows that just these 4 products cause between 19 and 33 million deaths globally each year. That's between 1/3 and almost 2/3 of total global deaths, or between 40 and almost 80% of NCD deaths. The proportion in the UK is less, but you can see this is vast, and it's not just about health impacts. Of course, it's about economic impacts. You know, people with NCDs struggle to work. There's a whole lot of knock-on implications that you will be seeing in your communities. But what was key to us was that the commercial determinants of health go way beyond those few products, because there are numerous other commercial products that cause harm and do so, you know, they cause avoidable harm. And even products that are meant to be beneficial to health, like pharmaceuticals, are causing avoidable harm, really because this drive to maximize profits. And the second key issue was that corporations also cause harm regardless of their product. And that's because of the practices they engage in. So if we think about labor practices, for example, Amazon warehouse workers have twice the rate of accidents as other warehouse workers. What about their financial practices? Tax Justice Network, the little green bits there, have shown that 40% of multinational company profits made abroad end up in tax havens. And they did this great report during COVID, which detailed that that's really equivalent to one nurse's salary every second. So the knock-on impacts of these practices can be massive. And then, of course, the supply chain practices, those can harm health when you've got, dangerous disposal of waste products that are damaging to health, destruction of the Amazon, and global warming, and so on. But the other key issue for me, and a lot of my previous work was in tobacco control, and tobacco control is really seen as this success story in commercial determinants, quite rightly, because we have had great successes. But the picture is not as perfect as people would let you know. So when we were working on getting standardized packaging in, and this is in a country where the industry is already denormalized, where already we have some of the strongest tobacco control policies in the world, and we have strong, tobacco research. My research group is probably one of the biggest globally working on the tobacco industry. It took 8 years to get plain packaging for tobacco products implemented. That's just unacceptable. We don't have that long to keep, to address these other issues, obesity, climate, and so on. So while some of us need to continue to work on those specific issues, we also need to address this wider system problem. And going back to tobacco again, that we've made huge progress, but that progress is stalling. So the graph there is global cigarette consumption. But if you look at smoking prevalence trends here, they've also stalled in young people, at least in some of the data, we're seeing increases in youth uptake and youth smoking. And in part, this is because we haven't really addressed the system problem. So any for industry profit is a bit like a balloon. If you squeeze its profits, it's going to find another way to make profit. So we're seeing emergence of e-cigarettes and heated tobacco products and oral nicotine and so on, all new ways to make money. And of course, we haven't really addressed those structural drivers or the power imbalance between the tobacco industry and public health. So what we were trying to get to in this series is this wider issue around the commercial determinants of health. So we came up with this definition, and you can read it for yourself. There's a few things to flag here. First of all, that this is deliberately neutral. This isn't some radical agenda to get rid of corporations or the private sector, because of course, private actors are incredibly diverse. There are some that are damaging to health, but there are some that are essential to health. And they play key roles in society. They innovate in ways that we need. They produce products that we need. They create jobs and so on and so forth. And in local authorities, you've got a role in supporting your economy. And small and medium enterprises actually make a disproportionately large contribution to inclusive economic growth and to employment. And they're very often actually the victims of this same system that is driving commercial determinants of health, because the real beneficiaries here are the big multinational and transnational corporations. And then in terms of health and the outcomes we're interested in, we made it clear that we're interested in human and planetary health. Those two are totally interconnected, of course, but also in equity. And I'll try and touch on the many ways actually in which commercial practices have a huge impact on equity. And then we were also trying to highlight these broader system problems, the systems, the practices and pathways, not just the products, not least because globally and nationally and indeed locally, I believe that the political and economic system is really key in driving health, and in most places is designed to put commercial profits first. So then we had to develop a model that would explain that definition. And this is the model. So there are 3 elements: the commercial sector here, the determinants of health subsection here, and the system element. So the system elements is all the text in black. And actually, this wasn't too difficult to develop, because actually I'd developed a model like this actually many years ago that we'd been working on in my team to direct our work. And the key reasons why we really wanted to do a model is it helps us think through and understand the problems and make sense of what we're observing. There are so many issues happening in commercial determinants that I think it's really easy to lose your way. And I actually bring a sort of a picture of this model, and I used to bring a picture of an earlier version. Whenever I'm on a platform talking about commercial determinants and people want to talk through solutions, I have it so I can remember what all the different options are, because there are so many, and there are some that will be more important than others, partly because they kind of address different parts, of that model or different parts of the system, or they play a key role in the system. And that's partly what we're going to try and disentangle through our research project. And so the model helps you understand these sort of interactions and the complexity. And from a research point of view, it helps us identify knowledge gaps. I just want to flag, we talk about commercial determinants, but this is not a competition between commercial and social and political and other determinants of health. These are all intricately interconnected, as this sort of news report and that picture really illustrates. And what I think is key about our work here, it's about bringing a certain lens by looking at the bigger picture, but through a commercial determinants of health lens, because that helps you identify, for example, reasons why progress on the social determinants isn't happening, and ways in which you need to tackle it, given the fact that actually we live in a very different world now than we did when some of these social determinants of health models were developed. So I'm going to go through the different parts of the model briefly. So here, and I'm going to try and be a bit technical. There we go. So in the middle here, we identify 7 different commercial practices which all overlap and reinforce each other. And we highlight that these vary from ethical or legal. For example, in terms of financial practices, that would be, full payment of taxes, to unethical, which might be, for example, tax evasion. I've mentioned Tax Justice Network's work, which is legal, but, unethical, to tax avoidance and for example, cigarette smuggling, tax evasion, such as cigarette smuggling, which is obviously illegal. And then what we're trying to flag is that the extent to which different business entities engage in these practices and the ways in which they engage, whether they're ethical or unethical, vary with the type of commercial entity, its growth strategy, and its business models. And the most egregious evidence really relates to the largest multinational and transnational corporations. And then finally, we just flag allies, because often these commercial actors, as you know, they don't act directly. Often their lobbying and their science is done through third parties, so their influence is hidden. Okay. And what we've done now is we've now actually got quite good understanding of some of these commercial practices. So in my team, we've done a lot of work on political practices and scientific practices. And there's overwhelming evidence that major corporations across different industry sectors use their political and scientific practices to oppose all sorts of policies, but including public health policies. And what we've been able to do is draw together that evidence across unhealthy commodity industries. And in fact, in science, look beyond the typical unhealthy commodities, also, identifying chemical industries and extractive industries and so on. What we've shown is they engage in the very same practices. And so we've now developed taxonomies and models of those practices, which means that we can start to address those practices, subject them to regulation and counter them. But there are other practices that have really, I think, been given less thought really within public health, so labour and employment practices. But over time, we've seen, a shift to really quite harmful practices. So a shift towards 0 hours and insecure work contracts. And this really came to the fore during COVID, where it was found not only did workers on insecure contracts have higher rates of COVID, but they were also more likely to die from COVID. And that included actually NHS workers. And so that those workers also have seen a stagnation in their salaries. But at the same time, executive pay has increased exponentially. And so the pay ratio between executive and average workers is getting wider. And that's obviously a huge driver of inequalities. And especially the case when we're seeing a shift in work really to the private sector, certainly in this country following privatisation and so on over many decades in the past. And then I just want to flag, I'm not going to go through all the practices. I want to flag reputation management, because that's often known as corporate social responsibility, and you will probably know it as that. Because I think this can be a problem within central government, but also local government, because it often involves the offer of funds. And so when councils are really short on funds, corporations come in to offer help, with financial resources or donations in kind. But this is not altruism, it is self-interest. And our work suggests that CSR is at best a public relations exercise, and at worst, really a tax-deductible way to shape policies that work against public welfare. And it's engaged in most heavily by corporations whose products are harmful. And you can see here that the general impact it has. So it tends to distract from the harms of a product. So here we've got AB InBev. And if you, last time I looked at their website, this is a big alcohol company, a big brewer. It really did not look like a brewer when I looked at its website. It looked like it was a sort of road safety company that dealt also in sort of safe drinking and driving. So they spend their time kind of distracting from their harms. And then they misdirect blame to others, generally to individuals. So this example here, this is Clean Up Britain, which was set up by Philip Morris, the big tobacco company. And at this time, it was writing not only to DEFRA, but to local authorities, which is how it came to our attention, because a couple of them contacted us to say, help, they're offering money and I want my council, not to take this money. And what at the time, DEFRA was considering a sort of polluter pays approach, a mandatory levy on tobacco companies to cover the costs of the litter they cause. And so Philip Morris created this organization. It was going to have videos that would blame smokers. You can see in the green text, smokers would be made to watch the video that would shame them. And when I looked at their website, it didn't have pictures of cigarette litter, which is A, the largest cause of litter, B, the largest cause of single-use plastics. It had pictures of tires. And then they use this to misinform. So here's some great work by some colleagues also involved in the grant. And they looked at alcohol industry funded education campaigns and founded that these were highly misleading. They basically encouraged rather than discouraged alcohol use. But all of these efforts, of course, buy them acceptability, they buy them access, and they buy them influence. And that underpins and enables all the other practices. So when we looked at, scientific practice, reputation management was key to them getting access to scientists, and the same in political practices. So it's one that I just wanted to flag because it's one that can be problematic. So then let's move to the determinants of health subsystem, or the determinants of health part of the model. You will recognize that this draws directly on the Dahlgren and Whitehead model, very deliberately, because, as I've said, we can't really disentangle commercial from other determinants of health. We're just trying to put a sort of commercial angle on this. And then I've flagged at the bottom in red this sort of local to individual, national to local. What we were trying to do here is just flag, obviously, at the center here, we've got the outcome, ill health and health inequities. And then we've got the sort of behaviors, the final routes to outcomes. So product use, consumption, access maybe to healthcare or exercise facilities, wealth, income, exposure to pollutants. Obviously, those occur at an individual generally and a local level. And then we've got environments, which are generally local to national. And then at the top, we've got political and economic systems, regulatory approaches, and sectoral policies. I'll run through some of these. And these can all be global to local. And I'm flagging that because I have heard some people present this as these blue levels are all sort of global or national, but that's not the case. You have your local economic system within your local health authority. And by reshaping that local economic system, you can obviously have an impact on the issues that we're talking about. So as I've said, this flags that health and equity at the centre in level 6 are influenced by a series of increasingly structural factors moving towards the outside, just as in the Dahlgren and Whitehead model. And those are factors then that move increasingly beyond an individual's control. And as we all know, despite knowing that we need to intervene at the most structural or upstream level, so much focus within health has been on waiting until people get sick. And the NHS cannot keep going on that basis. We have to prevent. But then even when prevention has largely been focused on individual behaviour change, often without changing the environments in which people are living and working and going to school and so on. So it's flagging very much those same issues that you all know about. So what I'm going to do now is just go through a few of those levels, starting at level 4 and moving upwards. So obviously our environments are massively influenced by corporations. So we have marketing here, absolutely we're exposed to marketing all the time. supply chain and waste here. This is the Grenfell Tower tragedy in trying to cut costs, using cladding that was not safe. This is a massive pollution in Mexico that had a huge impact on health, again, deforestation. Then we've got scientific practices impacting on our information environment. And that's a kind of new environment maybe to think about, but we're exposed all the time, increasingly now with social media, to information, or increasingly misinformation and disinformation. This is corporate social responsibility or reputation management influencing, school environments. This is a hospital. And obviously we've touched a little bit on labour practices impacting work environments. And these commercial practices impact environments in ways that are often highly inequitable. And we're seeing this both in terms of clustering of outlets for unhealthy products increasing with deprivation, but also advertising exposure increasing with deprivation. So that's a quick brush through environments. And then if we go to level 3, that's about sectoral policies. So obviously there are so many policies that impact health, whether it is public health policies or labour policies or tax policies and so on. As I've touched on, we know that corporations are influencing these policies, but also we know the policies that are needed, but they're not being implemented. And actually a paper recently by Luke Allen and colleagues showed that in topic areas involving unhealthy commodity industries at national level, progress is actually going backwards. And that's really because of commercial power and influence. But the interesting thing is, obviously, at local authority level, we are seeing progress in these areas. And we're doing an interesting piece of work in the project now that I won't talk about, but the results are starting to come in, looking at local authorities where they have got some advertising restrictions in place, successfully put them in place. And I think there are some positive stories to be told there that we can share with you in due course. So there are opportunities. So whilst we know that they influence those downstream policies, what is less well known is about level 2 influence. And there is also clear evidence that diverse corporations have influenced what I call upstream policies. And these are the rules that set out how policies have to be made. And we actually did this work years ago looking at tobacco industry documents, and we found that tobacco companies had clubbed together with a whole load of other companies, and they'd push to set rules on policy making that would make it harder to pass public health or environmental policies. And we've gone on to show that actually those policies, it's called better regulation in this country, and it's called better regulation in the European Union, is known by different titles in different countries. And actually they exported these sort of policy approaches from the US. And think tanks, there's one think tank that have labelled these approaches as a threat to democracy because they bring policy making under unprecedented levels of commercial control. And they do it by insisting that corporations or affected stakeholders are consulted early in a policy consultation and allowing them to feed in their evidence, which I haven't talked about directly, but that what we've shown is that evidence is often highly misleading. So very often our policy making systems are set up to advantage commercial actors. And then I don't even have time to talk about today, one of the other things is that then these policy approaches then get written into trade deals. And so then they kind of get exported around the world. And then we move up to level 1, political and economic systems. And again, the evidence is clear that major corporations and the very wealthy played a key role in promoting neoliberalism, in shaping the global political and economic order in ways that would advantage them. Again, just as they influenced policy, they did so through operating through think tanks, setting up university business schools and powerful organizations. And it's this really that has underpinned the sort of deregulation and the reduction in tax rates and so on that we've seen in this country and as well as around the world. And these changes to our political and economic systems have led to what we call in the paper a pathological system. And that's illustrated here in this part of the model. So we've ended up really with a system where commercial actors use their practices to shape all these issues, the political system, regulatory approaches, policies, and so on, in their interests. And governments, rather than holding them to account, often enable and empower them. We've reached a point, for example, where governments very often, if they want experts, they reach out to industry on a topic rather than reaching out to real experts. And as a result of these favourable policies, what happens is industries are increasingly able to externalise their costs. That means they make excess profits. By definition, it means they make excess profits, so their power grows. And then they use this power to shape norms in their interests. And so this is the system that has resulted. So over time, we've seen a shift to fewer, but larger multi and transnational corporations with greater power. They then influence norms, and I'm just going to say a little bit about norms here. So norms really are sort of social.
1 minute warning, Anna. Sorry to interrupt. I'm just conscious of time.
We won't talk about norms then. But norms are just, they've tried to shift our way of thinking. In turn, they use that to influence policies. That works to reduce their costs and increase sales. And that, of course, causes harm in both of those ways. They're not paying for the harms. They make excess profits so that the winners are on this side. Meanwhile, someone has to meet the cost of that harm. That tends to fall to the public, to public institutions, and so that reduces the resources they have for other issues like healthcare, housing, welfare. So the costs are socialized. And the outcome we're seeing, this is just one way of seeing the outcome, is that we're seeing over time this huge shift in wealth to the private sector. And the UK is one of the worst in here. I can never see it, but it's the black one, I think. So, private sector wealth is increasing and public sector wealth is now negative. And obviously that's got implications for governments, whether national or local, and their ability to address all these issues. So we need to act. And one key reason for doing this model is that it allows us to think about what we can do. So we can address commercial actors, we can address commercial practices, we can address the drivers, and then we can obviously implement interventions at each level of this model. And that may seem incredibly difficult to do, but just think about a good governance tool which is available on the ADPH website that helps address the political practices. It actually also helps address corporate power, because if industry is not in the room, if you're using that to help exclude industry from policy, you're actually addressing their power. And then it helps address both your regulatory approaches and your policies. So there are some interventions that may feel they're quite simple, but actually they can have far-reaching effects. And if we look here, we can also think about, obvious changes are changing the environment through licensing and planning, or changing policies through advertising bans and so on. But also thinking about your local economic model. So, a move away from a singular focus on GDP to more progressive economic models, such as those based on well-being or donut, could actually have a huge impact, because then those have an impact then on how policy is made, on the purposes of your policy and how you're trying to evaluate it. And I think there's also huge power from using public procurement. So it doesn't just have to be about regulation. You can also address commercial practices by enabling good practices. For example, using public procurement to prevent bad labour practices and encourage good labour practices. To, for example, avoid accountancy firms that engage or enable tax avoidance and so on. There we go. So that's me done. Thank you very much.
That's absolutely amazing, and I know that we'll be asking some questions into some of that, Anna. I think one of the really big challenges when you hear those big concepts is that all just feels so daunting. What do I do locally? Where do I even start? So, Peter, you're going to answer all of that for us, aren't you?
Absolutely. Thanks. Yes, Lucy, absolutely. With slightly less snazzy slides as well, I'm afraid to say.
I have some help.
So I'm just going to select them and share. Let's see. Is that coming up for people? Is that working, Lucy?
I can't see them yet, Peter.
Ah, okay. I have.
Oh, there it is. It has now
Is
appeared.
that working? Fantastic.
It has, yeah.
Thank you. Well, welcome everyone. It's very nice to see you all, and thanks for having me today. I'm very much focusing, I guess, as you said, on one of the levels of the model that Anna has described, but it's an independent model, isn't it? So actually, we need to learn from all aspects of what it takes to tackle the commercial determinants of health and think about the context that we work in locally and what we can do differently. So that's what I'm going to introduce to you today and talk a little bit, I guess, about some of the experiences for us in York and some things that we're learning nationally as Director of Public Health and as public health teams. I'm going to talk really to 5 broad points, and it's all about taking commercial determinants of health work into local practice. First of all, we're going to talk about building a local narrative. We're going to be talking about making key links, being clear on what the action is, and then clear on what the action isn't locally, and then painting a bit of a broader picture, and actually probably bringing it full circle into many of the areas and structures and models that Anna has talked about globally, locally, regionally, to bring it all together. First of all, building a local narrative then. Where do we start from when we're starting this conversation locally? If we're particularly, and I guess I am focusing very much on a local government structure and a local partnership where you have local leaders of the NHS, you have some of your local business leaders, your chambers of commerce.
Peter, can I interrupt just for a second? I'm really sorry. Are you moving your slides forward?
I have done, yeah. Has that not moved
Right,
forward?
they haven't for me, so I'm still on your
First one.
yeah, so it's not even
That's
presenting
very funny.
properly.
I've come out and I'll share again.
This might be my jinx because I'm a horrible technological jinx. So
Can you see anything now, Lucy?
I'm back to the one with your first slide and then all the little slides down the side. So it's not in presentation mode for me.
Well,
That's now the second. You might have to just click through in
I
that
do that
mode.
and do something over here with that. There we go. That's almost full screen. I hope that will do for people. How's that?
Okay. Yeah, I will let you. I will shout up again. I'm sorry to interrupt, but I'll
No,
shout up
not
again if
at
we're
all.
not moving forward.
It's good. Yes, this is just a summary of where I'm going with the presentation, which I think I've already done. The first I was going to talk about was building a local narrative, and this is the narrative that we're working with locally, and just how we might express this through work in a medium-sized northern city with public health issues facing its population in a similar way to many other areas. First of all, I'd start with mortality and talk about what we know that commercial determinants of health are affecting. So in York, every year I like to put numbers to things. I think it makes things real. So in terms of people who die under the age of 75, we see nearly 600 people dying in that category and in those age brackets. And we know from some of the research that Anna and other teams have done that non-communicable diseases constitute about 90% of that. So already you're at over 500 deaths in that category. Unhealthy commodity industries, we are told again from similar research, contributes about 45%. I think Anna, in your paper, you had a sort of a minimum and maximum, didn't you, on your slides? But if we just take a central estimate, we're getting to be able to tell people how many deaths are being caused by the types of things we're talking about in today's presentation, which is just a simple way of casting a bit of a narrative about what that means from a mortality perspective. We then add in the morbidity perspective, and that's often what really convinces people working at the front end of social care or the front end of a hospital or an NHS system that is worried about the level of demand that is seeing through the door every day. So in York over the last 10 years, we've and I put this in months because months is interesting, and this data is often presented in years, but we've added 27 months of ill health for males and 43 months of ill health for females. So that's essentially our increase in unhealthy life expectancy, and typical stories that other local authorities would be able to tell as well. But it's just again to add some to narrative to the mortality and to talk about morbidity. Then we might talk about morality and the types of argument that would get often our local elected members, but other partners engaged in talking about the commercial determinants of health. So a thing that I've noticed that is often quite persuasive is the fact that we are seeing our availability, accessibility, and advertising, those 3 A's, we're seeing them clustering in more deprived areas in quite a deliberate way that people can immediately say, oh yes, I know that ward, and you're right, actually, we do see those bus stop adverts more regularly down that road. Why do I not see them in that affluent ward over the way? We can talk often about the effect on children and young people with commercial determinants of health, and the fact that increasingly I think we are understanding even more that the data being collected on our health behaviours is enabling companies to progressively improve their algorithms and target to particularly children and young people some of these unhealthy commodities. We can talk about the addictive properties of these commodities, and the fact that a lot of them drive behaviours which in no way have any sense of individual control over what the behaviours are. And often the behaviours, for instance, smoking tobacco or starting to drink alcohol, are behaviours that are started when the brain is most plastic in the late adolescent ages. And actually, in that sense, we're not talking about people's choices, we're actually talking about people's lack of choice being taken away by these products. Productivity and economic drag arguments are often used because local authorities in particular base a lot of their income on how well the local authority is doing, whether it's through the base of council tax and the amount of council tax benefit that's given out, or whether it's for business rates and local employment and the rates that are paid. Propping up in some senses the financial models. And then a very simple phrase which is similar from how Health Foundation language, people may be aware of the building blocks of health research. Local people are dying area because of where they live. It's just a really simple way. And then finally, in terms of the local narrative, talking about the actual money, and there are some really good tools there that people on the screen may or may not know about. So from the Institute of Alcohol Studies, a way of quantifying what a local area is finding in terms of its economic drag through the cost of alcohol. That's the first diagram, and then the second is very familiar to lots of people, the Ash-Ready Reckoner, which just shows us again what the cost of tobacco would be to any local economy. Moving us on, and apologies because there are some animations here which obviously are not coming out, but I wanted to make the point here that we can come up with lists of industries, and that's what we've got on our left-hand side of the screen, and we can quibble, and if I'm feeling very adventurous, I will list all of these, and I will go down as far as social media, and I will get into conversations about big tech driving our purchasing, etc., etc. If I'm feeling uber cautious, I will talk about tobacco, because if there's one industry that the vast majority of people are sold on the idea that it's a health harming product and we need to act to regulate, we need to act to take decisions in terms of limiting the availability, the accessibility, affordability, tobacco is certainly up there. So we can shift out these different industries and we can talk about a variety of different commercial actors working in this space. I think that's helpful sometimes, but actually, I think the evidence would show that the most important thing is to talk about what's on the right-hand side, which are the tactics of these industries. And Anna has sort of elucidated a lot of this stuff, and I don't need to go into this in any huge detail. But we know that big tobacco shared its playbook with big food, with big pharma, etc., etc. These things have been circulating, and these are the types of things that they've been doing for many years. They've been denying and undermining the science. They've been aggressively marketizing, been shaping social norms. They've been undermining public policy decisions and getting in bed with government in a variety of clever ways. And actually, a real emphasis on tactics locally is often, I see it as winning the argument more than listing out specific industries. Being clear on what the action is, on our right-hand side is just an illustration from a paper in BMJ Global Health, just demonstrating that locally, obviously, if you are a jobbing DPH or a public health manager or whatever is working in a local authority, you do have to recognise that you're part of a system. And again, Anna's diagrams are super helpful here, but our local efforts very much form part of an international, regional, local sort of network, and we have to understand where the action needs to be in the right places. So I've given a few pointers on what the action can be locally, and shamelessly stolen them for some work done for us here in Yorkshire and Humber in our consensus statement that the Directors of Public Health released on commercial determinants of health. really focusing efforts on a number of things. So the ways in which an authority can shape availability, accessibility, and the pricing of our commodities. So how can we work that when products are placed in shops, in environments, when products are able to be purchased and not able to be purchased according to the regulations in terms of people's ages, and then particularly in terms of the pricing of those products. We know those three things are well recognized within the tobacco world and other worlds in terms of action, and there are certain mechanisms, licensing being one of them, in which we can shape that. Advertising and marketing, which we'll come on to a little bit, but it's absolutely part of what local authorities can do, and Anna has always already referenced the work that's been done around advertising policies that authorities have. Partnership and system leadership, so actually just talking about the commercial determinants of health openly and being probably as vocal about that as we may be about other aspects of things which shape health, the social determinants of health. You know, for every time we talk about housing and education, we probably need to be talking about commercial actors in the space that we have locally. Shaping the environment through planning is enormously important, because where we place things is often part of where people buy and sell things. Framing and advertising, so thinking about the way in which we talk about health. And this is really important, because in public health, we sometimes get in the tendency to lifestyle drift and talk about an individual's behaviors and talk about, you know, the choices that they're making. That is what industry wants to do. So actually public health communications changing its script is very much part of this. Good governance and conflict of interest, that's very important. Again, Anna has mentioned, I will self-declare no conflicts of interest on this call, which I'm sure you're glad to know. But actually there's plenty of it going on in local authority spaces that you just have to dig a little bit and you find some very interesting connections going on. And then participation in advocacy, so the extent to which locally we can join up with regional networks through the ADPH and join up with, you know, research that we've got here represented today, and other advocacy such as ASH, such as Obesity Health Alliance, Alcohol Health Alliance, and those type of actors. Some good examples of this will all be very familiar to people, but, you know, authorities, even just thinking locally here, we've got comprehensive ad policies, and in York we've got an ad policy which covers high fat, salt, sugar foods, but also gambling, alcohol, predatory loans. We didn't do a full fossil fuel, we weren't brave enough. Sheffield did it. Hurrah to Sheffield, jolly good. We chickened out in the end, but I think that's definitely one for people to consider. But going beyond just high fat, salt, and sugar in terms of ad policies, lots of examples of really good pushing back on planning applications, lots of examples of pushing back on things like community alcohol partnerships funded by Diageo and Alcohol Education Trust Materials, hot food takeaway supplementary planning documents, essentially with 400-metre zones around schools and exclusion zones. Licensing, so just having a really clear evidence base to when you object to a licensing application. Again, public health messaging, I've talked about that framing and values-based framing. Reframing transport schemes is really interesting. I learned this week, don't use the word corridor. It's what car makers want you to use. Call it a street. Don't call it a transport corridor, because that makes people think it's designed for the car. So just things like that we can reframe. And then objecting to things like adult gaming centres, which again recently has been led nationally by some directors of public health. So just a few examples of where that's happened, some headlines there, just to show that there is lots of local action going on. I've just restricted myself to Yorkshire and a bit into the northeast here. And just a little tip to beware of local context. This is where we got to. People may know that York is the home of chocolate. We are the Rowntree and the Terry capital. This is where chocolate has been made historically in York. And so, of course, we got very much accused of nannying when we tried to ban advertising of Twixes, which was highly controversial. So every local area will have its local industry, will have its local thing. My tip is to really focus on the global massive conglomerates. This is not about York Brewery. This is about Diageo, etc., etc., etc. Then being clear on what the action isn't, and I'm aware of the time here. The action can't be naivety. It can't be that public health teams aren't aware of these things and don't frame them in. That doesn't help anyone. But it can't also be despair. So the graph on the side is just to show that there's good research to show that if we want to halve obesity in the UK, 50% reduction, actually that's only a 217 calorie reduction per person. And so often people will scoff and say, oh, that bit of regulation, we found it only reduced by an average of 11 calories. But actually, when from a population mean perspective, you're trying to shift the dial just back a little bit. Actually, any population universal approach, which reduces, for instance, calorie intake even by a small amount, contributes to what is a relatively small goal in meeting a massive population aim of BMI reduction. We have to be clear on the action isn't influenced through partnerships, so we can't really respond to industry offers of partnership with any sense that it could be free from influence. Industry self-regulation and voluntary deals have been shown to not be as effective as people think that they are. Individualizing the problem, so language which talks about people and their choices, and it's back to that cigarette example of shaming people who drop cigarettes, again don't work at moving the dial on commercial determinants of health. Treatment frames don't work. We still offer treatment in areas such as weight management, tobacco and alcohol, but actually framing things and the problems we've talked about in terms of the massive rise in non-communicable diseases through the idea we can treat our way out of it is essentially emptying oceans with teacup stuff. We're really not going to get there. It's not predominantly about local businesses, as I said, so concentrate on the major global actors, even if you're talking locally. And we can't imagine we market our way out the problem. It's well known that the public health grant is approximately similar to the Coca-Cola marketing grant. So we know that actually we'll never produce enough campaigns to do this. There's got to be some action with some teeth. And then finally, painting some broader pictures. So actually, locally, you may feel very helpless, but actually the concept of the Overton window is that within public discourse, there is a window of things that are acceptable to say. And actually, I think we are slowly moving that window where it becomes acceptable to say there are some commercial actors that are harming health, and we should take quite strong action to limit the ways that they can advertise and make their products as accessible and cheap as they want them to be. This is a screenshot from Grant Ennis's Dark PR, fantastic book, highly recommend it. And it sets out a set of 9 devious frames that industries will use. I highly recommend having a read and thinking about how we can incorporate that into our thinking. Would encourage people to join with advocacy, thinking about really clever ways of framing the issue. I'd point to the Holding Us Back report from ASH, OHA and AHA recently, which just was really good on that economic argument for why some of these industries are harming local economies. Working regionally and nationally, and of course working in research and good practice, we need to forward really good academic partnerships to understand the ways in which these things are mediated beyond the local and into the global, and what works in terms of the action, because none of us wants to do ineffective action that will just lose us friends and sabotage the work that we're trying to do right from the off. Thank you very much for listening, everyone.
Peter, that's great. Thank you so much. And two very complimentary presentations about bringing it to reality for practitioners. And I know that some of the questions we've got in the chat are about actually some of that, what can I do locally? The first question we had, Anna, builds on something you touched on very briefly in your presentation, which is about examining the role of advertising and the effectiveness of local policies on this. And I know that this is one of those things that absolutely falls into that money trap, and a question that has been posed later about that balance that we have in local authorities, about we need to be bringing in external income at the same time as we're trying to ensure that we've got influence-free, using your words, Peter, relationships with some of those big providers. So Anna, I don't know if you wanted to just touch a little bit more on anything around the effectiveness of advertising policies.
Yeah, so there is, you can look at the evidence in 2 ways. There is clear evidence that advertising increases consumption, okay, and there is also evidence that advertising bans that then help, reduce that consumption or consumption of harmful products, and that exists at national level. But also there are now evaluations, say, of the HFSS advertising bans at local level. So it may be that one thing we could help to do in the project is sort of compile some of those sorts of evidence in a place that's more accessible for people. So it'd be useful to know if that sort of thing is is useful. I think the other thing, as one of the challenges, so there is absolutely evidence there. I think we need to get probably smarter at two things. One is looking not just at the health outcomes, but looking at wider economic outcomes. So a colleague of mine just a couple of weeks ago published something evaluating the ULEZ, the ultra low emission zone in London, and not only looked at health impacts, but looked at participation in the workforce, reductions in sick leave, and so on and so forth. So I think we can get better at trying to look at the wider impacts. My understanding on advertising is it can actually be really hard for local authorities to get data actually on the spend locally because of the way that billboard space is contracted out. So I think there are some complexities to sort of dig into. But there actually are some other projects looking at marketing. But just more generally, there's a wider issue, I think, also in how we are always evidence-based, and we feel we need evidence for everything. But I think as we move forward in this area, and we will have to be implementing policies for the first time. So you might be the first local authority to do X. And so I think sometimes it's about stepping back and just using the evidence that you've got. We know, like if we take the plain packaging of tobacco products, for example, that was in place in Australia, but it hadn't been evaluated. So how do you make that case? You make the case because there is clear evidence that advertising leads to consumption. And, so therefore you need to reduce the advertising. So I think we have to also get a bit more sophisticated in how we harness evidence and not get sucked down by opponents into having to produce evidence on every single thing or in every single different jurisdiction. I don't know if that helps. But...
That's great. Thanks, Anna. And Peter, can I bring in, there's a couple of questions in the chat, particularly around that, how we balance that push for commercialization in local authorities against the sort of activities that you've been describing, and how are we aware? So a really good question of how do you become aware actually of how embedded some of this in, particularly where you've got strong local industries or football clubs or that sort of things that bring a real profile to the area but actually are quite challenging in this space. How have you overcome some of that?
Well, I think local knowledge is really important there, and it's why I'm quite a firm supporter of public health being in local government, because I think it gives you the ability to be able to sit around the table and just observe some of the dynamics. And sometimes that is what's needed, that almost a period of listening, observing, and then understanding where some of the quickest wins will be, and what some of the almost the cyclical schedules will be. With our advertising policy, I had the conversation first in 2019, and I was a registrar at the time, and it didn't go anywhere. Our transport policy, our advertising policy, wasn't due to be renewed for a certain amount of time. A couple of administration changes, we get to sort of 2024, and it suddenly is the right time, and because you've known the right people and been in the right conversations, you're the right person at the right time. And I think that's what happens, and shouldn't take the credit, because in the intervening period, lots of other colleagues did lots of hard work to try and get everything ready, and then didn't get any of the credit. So I apologize to them, because they really did the work. So I think it's the famous definition of public health as an art and a science. We absolutely need to understand the science behind what works and the evidence, but then be able to apply the art at the right place at the right time to get something across a line like that. I do appreciate, I think the extent to which a local authority can act on this probably will be in some way mediated through its political composition, because I think there are some administrations which are going to welcome this more than others. But then there are framing aspects too, and I think particularly if we're thinking about recent political events in the UK, and if we're thinking about particular five-party sort of politics, and where you're never absolutely entirely sure what your administration is going to be, it's probably incumbent upon all of us in the public health community to think about, if I were a public health professional under this particular shade, what are the types of arguments? Are they economic? Are they targeting inequities and what the white working class community or whatever it is that would actually make the case, and in other areas it would be, you know, ethnic diversity, or it might be, you know, younger population or an aging population. There are ways, I think, that you can look at your JSNA and your population health need and say, how would commercial determinants of health arguments be framed given our local need, and I can express that to members in a way that will win at least some battles, if not all.
I think that's really helpful, because David Monday's asked a question about how you influence councillors, and I just wonder if either of you have got any thoughts. My experience, and I'm in a Labour authority, is that actually councillors are quite amenable to this, but I've had almost more challenge with officers. I'm just wondering whether, Anna, Peter, you've got any thoughts about, do we need to get smarter at tailoring our messages for different decision makers? And what have you learned, either through your practice, Peter, or through your research, Anna? Who wants
Peter,
to
do
go
you
first?
want to go, and then
Yeah.
I'll kick off. Thank you, and that's very kind of you. I mean, I think that's absolutely my reflection, actually, is that actually the officer conversation was sometimes harder than the member conversation. The income aspects of the advertising stuff, and we are talking a lot about advertising, I would like to definitely make sure our conversation would broader just than the advertising. The income aspects of that, you can point to what TfL found, or the independent evaluations of what TfL found. People may then come back and say, but how does that map onto a very different advertising market space? I think my understanding of that is that actually there's a mediating factor in terms of advertising buyers. So you don't just go straight to a company and say, would you like to advertise here? There's a buyer, but there's also the Clear Channel, JC Deccal, other companies are available type thing, the companies that sit there who own the physical space. And actually those intermediate bits of the picture are changing their models because they know this is coming potentially through a national move, or lots of authorities are taking it on. And in a sense, I don't think, because they're not selling unhealthy commodities, they don't really care. They just want the revenue. And so actually, if it can be seen that you can swap out and still get as much advertising space that's just as lucrative, that seems to be what the companies are doing, with no huge impact on profits. I think some other areas, you know, where that there might be sort of myths or misconceptions about that. It is just about trying to show the TfL evidence. It is about to say, you know, I see a comment in the chat as well, that if you're not entirely sure what the income aspects will be, a local authority has a statutory duty to improve public health. So if we've got uncertainty on the one hand, and we've got a statutory duty to improve public health on the other, action actually is better than inaction in that particular circumstance.
Brilliant, thank you. Anna, your thoughts on that?
Well, I'm not sitting there in the hard seat where you guys are. I can say that in the project we have got one work package that's looking at barriers and facilitators to action, and so we will, you know, over the course of time have some feedback for you. And I think one of the complexities is that I think the commercial determinants is a really unhelpful framing, actually, because it kind of it sounds very anti-corporate and anti-business. So I think what Peter was saying earlier about the framing and the language is so important, and that's one thing that has you know, come up for us. And I think we've kind of got this catch-22. So the bigger wins, because of the scale of the harm, will be around these, you know, tobacco, alcohol, food, you know, fossil fuels, and so on. Those very sort of commercial determinants. But actually, the wider wins might come, and the longer term wins might come more from, you know, harnessing others in the local authority. You know, the move towards sort of inclusive economies, trying to look at the sort of well-being approach. So thinking outside the box, perhaps, and then I think you might actually find more allies than you think by sort of approaching it differently, approaching it through their lens. But you can understand the wins that you will get, because if they're trying to develop more inclusive economies and support SMEs, and you use procurement positively, all of those things will also address the commercial determinants. And you know, I think one of the things we need to see is that, is there a way of sort of harnessing that, and then gradually in the places where the sort of getting straight in on the unhealthy commodities is difficult, and then bringing these in gradually. Does that make, I don't know if that would ring true for you guys, but I think those are the sorts of, I think there are different allies that perhaps are not being tapped into.
I think that's really helpful. I'm going to try and finish this on time. So there's a question from Claire Chong Lee, and I want a one sentence answer from each of you. What in your experience has been a quick win? Peter, do you want to go first?
Fruit on the right at the front of the queue in our council's main cafe, which loads of people come to every week. It was just a really simple conversation. They moved it, substituted out brownies.
Excellent. And Anna?
Well, I touched on some work that we're doing, which suggests that actually it is going to be easier, at least in some places, to get ad bans through than people think. And obviously it depends on the location, but I think there is some quiet action that can happen. So I think some of this will be easier.
I think from the work that we've done, and I know, Peter, that you've done similar as well, it's something about also using the structures that already exist. You've already got a licensing team. How can you just add into some of that structure that's already there through licensing work or through having some really good evidence to support them in their decisions? That has been utterly fascinating, and I think we probably could have done a good 3 hours just learning that. So thank you so much for giving us such a rapid run through of both of your work. Thank you everybody for coming and joining us this afternoon. Slides will be shared so that you'll have access to the tremendous tools and learning from both of these colleagues. And thank you again to everybody, but particularly our two speakers, and for Laura and ADPH for helping to organise us. Thank you all very much.
Thank you.